Power Living with Kimberly Langford, where inspiration meets empowerment. Kimberly is a nurse executive, leadership coach, Reiki master, and your guide on this journey to whole person wellness.
Woohoo! I can't tell you how excited I am. Today, I'm so excited to get to work with you, Rusty. So, as if Rusty wasn't a superstar enough, we get to have a delicious conversation with somebody I hold in my very highest regard as a real, just as a human being and a leader in the healthcare industry. Nelson Griswold is the head of Next Gen Benefits Network. And I would say, I think Rusty, you'll agree with me, he's probably one of the most outspoken and respected leaders in the employee benefits industry. He's not only a best-selling author and strategist, but he's the architect, if you will, of Next Gen Benefits movement, which is really reshaping how employers and advisors really design and build their self-funded health plans. He's trained thousands of benefit advisors, spoken in nearly every single state, and is known for helping employers who really are the customer in our industry to take control. We hope they take control of the healthcare supply chain. And I come away smarter every time I get a chance to listen to Nelson. So he's really made it his mission to call out mis and malaligned incentives in our industry, cut through opaque carrier games, and show employers how to reclaim dollars, all while improving outcomes, especially in high cost conditions like things near and dear to our hearts over here, specialty pharmacy, cancer, dialysis. And his work really does challenge the status quo, that traditional insurance playbook. And he replaces it with bold, transparent, and outcome driven models. I'm so happy you're here, Nelson.
Kimberly, I'm blushing from the introduction, but thank you. It's so great to be with two of my favorite ladies who are fighting the good fight every day to improve the quality of healthcare and lower the cost for the people who are paying the bill, which is not the commercial payers, also known as the carriers or the BUCAs, but the employers and the employees. So it's great to be here.
Yeah, and I think a lot of times we don't realize that they are. Now, as a nurse, I keep the member in the center. That's near and dear to my heart. But I think we forget in the industry that it's that employer sponsored health plan, that employer that's putting those things together. That's real. They wield the power. And I think a lot of them don't know it.
Well, they absolutely don't know it. They've been lied to in what I call healthcare's big lie, which is you can't control the cost of healthcare. And the carriers, the BUCAs, the Blue Cross, United, Cigna, Aetna, BUCAs, will tell you, we do our best, but we can't control the cost of healthcare. And so healthcare costs will go up every year. So will your premiums. Get used to that. And it's a lie. It's an absolute lie. Of course, you can control the cost of healthcare. When did healthcare become exempt from market pressures, supply and demand, and supply chain management? It's not. It's simply the insurance companies ensuring that they have an excuse to raise premiums next year because they have allowed, even encouraged, healthcare costs to go up, justifying their increase in premiums, which is their revenue. And they have a fixed profit margin because of the MLR clause in Obamacare, capping their profit margin. So a fixed profit margin on a larger number is a larger number.
Right.
So no, it's employers have been lied to, misinformed, misled, and basically, as one CFO said to me, have been treated by the insurance industry like a bunch of mushrooms.
Well, they're kept in the dark.
Kept in the dark and fed a steady stream of cow manure.
So I'm just curious, with that in mind, what was it that, was that realization, what was the catalyst for you? When you think about what you've built, what you're building, what was the catalyst for you to, embark on this movement that you've created, the next gen benefits?
Until 2016, I had been working with employee benefit agency owners to, before Obamacare, just to be more effective for their clients, more successful. After 2014, when Obamacare came, actually after 2012, Obamacare had been passed, and we were seeing it, in the headlights coming towards us. I've been working with agency owners to survive and thrive in that post-Obamacare era as an employee benefits agency. In 2016, I met someone you both know, a woman named Deb Alt, a nurse, and the founder and president of Alt International Medical Management. I was introduced to Deb. I said, "Hi, how are you? What do you do?" And she said to me, "Well, we guide employees to the highest quality health care so that we can save the employer money on that care." And in my little brain is running, going, a claim is 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 a claim. And I said to Deb, you can't control the cost of health care. And both of you can hear her say this as she took a step back. She said, "Well, I never got that memo." And that was the beginning. It's like, seriously, you can control the cost of healthcare? Tell me more. So she explained what they do at AIM. Then I learned, okay, wait, but the insurance companies won't let you do that. No, you've got to go self-funded. You can't be fully insured. And you can't use the insurance companies as your administrative services only provider, because they will not let you control the cost of healthcare that way either. So you have to go with an independent third-party administrator.
Yeah.
And then you can start to use techniques like, for instance, not that you have to, but reference-based pricing, for instance. You can carve out pharmacy and go with a fiduciary PBM and do cost containment on specialty meds and expensive maintenance drugs. You can look at surgeries. You can look at dialysis. You can look at infusion drugs. You can look at a wide range. It really, if patients need to spend money on it, we can save money on it, because everything's overpriced in healthcare in the status quo world. So that's what started it. It was Deb Alt telling me she was doing something that I didn't believe was possible. And once I understood it was, Katie borrowed the door. Let's change the employee benefits space. Let's change employer-sponsored health plans, but let's change healthcare.
Oh, I think you can probably hear Mark Testa speaking right now, right? What happens when you bring a seat for a clinician to your benefits table? Things change quite a bit. It's interesting, as you talk about, this whole space, and I think there's two paradigms that people consider. Your savvy folks, they think about, this whole self-funded arrangement. And I don't know, I remember being at a conference with you one time, and when you go to the conferences, you think, oh, there's such an army and we're all rowing the same direction, and woohoo, we're going to make a big difference, and there's not enough of us. But it does feel like the momentum is slowly picking up pace, where I think, self-funding is becoming more palatable, especially as we have more savvy advisors out there teaching employers how to take control of their health spend. But there's also the other side of the camp. Now I can hear Tom Mueller in my ear, where we argue sometimes very respectfully on the pros and cons, if you will, of letting government take the helm. Won't government? What about Medicare for all? That's going to fix all our woes. What would you say, in terms of looking at that dichotomy, if you will? What about, putting a lot of momentum in this, self-funded arena where we're really bolstering, bringing in employers and patients to take control, or should we just throw our hands in the air and let Uncle Sam take care of us, as he always does? Wink, wink, nod, nod.
Well, government run healthcare is something a lot of people seem to want, from Bernie Sanders and Senator Warren, uh, AOC, whose name I never can remember, but the initials will do, are all calling for the government to take over healthcare and run healthcare. If you, if you like the efficiency of the post office, the wait times of the DMV, and the compassion of the IRS, you'll love government run healthcare. So let's avoid that. So next gen benefits, which is not a benefits agency, it's not a health plan. Next gen benefits is just a model, an alternative model for employer sponsored healthcare. And what next gen benefits really is private sector healthcare reform in action. This is the private sector doing what government can't and won't do. Certainly, we hope they won't do it, but they can't do it. They can't fix healthcare. They'll just screw it up worse. But the private sector is taking control of the healthcare spend in that company. It's company by company. This is like urban warfare, going from house to house, clearing out the enemy. It's slow going, and it's not easy because there's a tremendous amount of inertia, Kimberly. There's a tremendous amount of Stockholm syndrome.
Yes.
The BUCA carriers, again, Blue Cross, United, Cigna, Aetna, BUCA, the BUCA carriers have been abusing employers for so long, but holding them captive. Where can I go? I either go to Blue Cross or I can change to Aetna, but they're all the same. Deb Alt calls it just another shade of
Well, and they're
blue.
all running the government plans too.
Yes, they don't give you any options, in part because Obamacare took away all the options. It standardized the plan offering to a very large extent. So but employers go, well, I only have these four choices. They don't have four choices in most markets. They have maybe two, possibly three choices in Blue Cross, United, maybe Aetna, but they won't have Cigna, or maybe they have Cigna, but they don't have United in a certain market. The employers see themselves as trapped, as
Right.
imprisoned by these choices. And the Stockholm syndrome, if you'll remember, is the phenomenon of someone who has been captured and held captive, falling in love with and
Yeah.
becoming sympathetic with the captor.
Yeah.
Well, they take care of me. And we hear employers tell us, well, we've been with Blue Cross for 8 years. They do right by us. They take care of us. I'm thinking, well, how do you define that? The guy in the ski mask that jumps out from behind the dumpster in a dark alley and points a gun at you, he's taking care of you too. Well, he's taking your wallet and your watch. But this is exactly what the insurance companies are doing. They're actually what the insurance companies are really good at is separating employers from their money. That's what they're really good at. They're not good at running healthcare. They're not good at quality of healthcare. They're certainly not good controlling the cost of healthcare, but they're really good at separating employers from their dollars.
Well, they're really good at making money. That's a profit, right? That's what they're driven for, is profit. And, it used to be, people used to think, well, if I call the number on the back of my card, they're going to tell me, how to find a good provider. Well, they'll tell you who's paid to play. They're not going to tell you, your Deb Alts will, where can you go for the high quality care? And I think a lot of people mistakenly think the consumer has been taught to think, if I pay more, I'm going to get a greater benefit. And
Or if
it's,
it's a recognizable brand. I think this
yeah,
is where brand and commercialization has really done a disservice to have any type of correlation to quality. Just
yeah,
because they have a commercial or they have a great teaching hospital or they have a great brand presence, as Nelson mentioned, in a specific market as an insurance carrier, that has equated to I have a quality health insurance plan, when in
yeah.
fact, I would define a high quality performing plan based off of true satisfaction and clinical outcomes. And
Hmm.
it is misled severely, I think, by misrepresenting through commercialization.
Rusty, you make an excellent point, and I'll give you an example. In the Cleveland market, there are, I believe, five or six healthcare systems. The
Mhm.
premier, of course, is Cleveland Clinic, and Cleveland Clinic is renowned internationally. It every year it gets the award for the top heart hospital in the U.S. And if you look at objective quality data, Cleveland Clinic is excellent when it comes to heart.
Mhm.
But if you look at overall quality, and this is objective, this is using the Quantros system that Quantros uses data that the hospitals themselves have submitted to CMS, Centers for Medicaid and Medicare Services, and then risks adjust and puts in all the right algorithms so you can compare hospital to hospital to hospital. If you look at overall quality in the Cleveland market, out of five healthcare systems, Cleveland Clinic ranks fifth out of five, maybe fifth out of six. I can't quite remember, but it's fifth
Hmm.
in overall quality, which means you can get better quality going to something other than the brand name. But everybody wants to go to Cleveland Clinic because it's Cleveland Clinic. And it's interesting. In every other part of our life, uh, you know, uh, I don't know, Rusty, you get an allowance to go get a new car, and
Yeah.
it's $90,000. It's like, oh wow, I'm gonna get a nice car. Oh wait, I'm sorry, we misread that. It's $40,000. You're not going to get nearly as nice a car. Or if I give you a clothing allowance of, I don't know, $10,000 to go get a new wardrobe, I bet you could pick a really nice wardrobe, really fine clothing. Oh no, I'm sorry, it's 1,000, not 10,000. The quality of the clothes you're going to get are not as good. The same with food and
Yeah.
on, except healthcare.
Yeah.
Right.
You said it. There's actually an inverse relationship. Everything else is a direct relationship. You spend more, you get higher quality. You spend less, you get lower quality. In healthcare, you spend more, you generally getting lower quality. You spend less, you're generally going to get higher quality. Actually,
Yeah.
you get higher quality, you spend less, and there's the
Correct.
correlation. But
And
but
the
nobody
ability to
understands that,
research.
and it has to be explained because nobody wants to go to the least expensive healthcare facility.
Except
Well,
us.
research around a lot of the quality metrics and the consumerism associated with healthcare is very opaque. And so it's very challenging, to your
Yeah.
point. How do you define somebody taking care of you? It's very difficult. If I was to purchase a car as a consumer, I can spend extensive amounts of research, have unbiased independent review opinions by organizations that are not, proprietarily related to a specific brand. I can research a lot of information online. It's just all readily accessible. But in healthcare, it is so difficult to find out that information at a quick glance, let alone when you're a patient in crisis. You have very little time or mental
Yeah.
capacity to compartmentalize and focus on those metrics
Right.
with whatever else you're dealing with, socially, emotionally, economically, etc., as well as your actual healthcare. It is stacked against everyone, and so it's really important to your point, to have key players like Deb Alt, who are there to advocate and direct in that moment with data-driven decisions, which I think is really where we're seeing the biggest opportunity in the healthcare market to continue to drive cost transparency and higher quality performance and metric awareness. Is really going to be in having those folks who have access, sharing that access and that knowledge at a higher level. And it's unfortunately something that we aren't seeing by those who have commercialization of their products, because I don't think that they can stack up well to that. And I think a lot of folks misunderstand that by putting in those navigation or advocacy that you're telling a member what to do. Or a patient, but in fact, that's already happening, but based on whose profitability is going to be maximized, right? So a hospital is not looking at all of the different MRI or surgical centers that are independent versus their own to decide where to direct a patient. They're doing it based off of their own profit center. And so I just always state it's already not a choice. Why not let it be a choice, but based on quality and cost as the final data-driven decision?
You know, most next-gen plans that incentivize employees to utilize the highest quality care when they're exposed to that through the navigation, through the nurse advocate. It's voluntary, and the employee usually has their out-of-pocket deductible and coinsurance waived, which on a major procedure is somewhere in the $8,000 to $9,000 range, $8,000 to $10,000 range. But they don't have to if they don't want to. But why wouldn't they? But let me say something about the BUCAs. And I'm going to make a statement that's incontrovertible. It's inarguable. I challenge anyone to argue this point with me. We know the highest quality doctors and the safest hospitals. The quality metrics are out there. Yep. Are they perfect? No, they're not perfect, but they are really close to being perfect. They're really good. I've had access to those through my relationship with Deb and AIM. I'm pretty sure that Blue Cross, United Cigna, and Aetna all have access to that data. They know who the best doctors are. They know who the safest hospitals are. Conversely, they know who the dangerous doctors are and the unsafe hospitals, mostly due to infection rates. But they don't tell their members. They won't give that information to their members. Here's my statement. Yep. The insurance companies are more concerned with protecting dangerous doctors and unsafe hospitals from their own bad outcomes scores than they are protecting their own members from dangerous doctors and unsafe hospitals.
Got to protect the provider contracts.
That network is the most valuable asset the insurance companies have. Foolishly, people think it's important to have lots and lots of choice, which means lots and lots of bad doctors. Did you know that almost 40%, 39 point something percent, almost 40% of paid malpractice claims? I'm not talking about malpractice lawsuits. I'm talking about the malpractice claims that the insurance company said, yeah, we'll pay that. Or they lost in court and had to pay it. 40% of those paid malpractice claims are due to 3% of doctors. Now, I want to know who those doctors are because some of them are still practicing.
Or they went in the military.
Nobody will tell you who they are. The insurance companies won't tell you who they are.
Yeah.
What was your comment?
Or they go in the military. I could share some stories over pizza and root beer. Yeah.
Are you talking about the VA?
We'll just say, pizza and root beer conversation. I know a few specific.
Okay.
Yeah.
And that's the thing. So I'm going to give our listeners some advice. If you don't have access to the data on which are the best doctors and which are the dangerous doctors, here's the shortcut to that. Ask a nurse, because the nurse knows. And
Yeah.
the nurse will tell you. Now, the doctors know too, but the doctors won't tell you. They will tell their family and their close friends. They will not tell their patients. I guess it's professional courtesy.
I don't know.
But
I've
nurses
heard a few
know and
doctors,
nurses
when you
will
hear
tell
a
you.
doctor yelling at another doctor. Yeah, I've heard a few. So, but you're
Well,
right.
they may peer to peer, but there's like this thin white line, just like there's a thin blue line. Police
Yeah.
protect each other,
Yeah.
doctors protect. We see this in the medical board's treatment of egregious physician behavior,
Yeah.
and yet that doctor is still practicing. Why?
Yeah.
So ask a nurse. Nurses are a patient's best friend. Can I get an amen, ladies?
You got
Amen.
a name in. Yeah.
I
Everybody needs a
always
nurse in their pocket.
I always state who helps the doctor if and when something doesn't go right. And it might be a nurse. If you're a surgeon, it might be a physical therapist. There's somebody helping to clean up. And that is really important to ask them who they would recommend as well, because they really see it from the inside out.
That's absolutely right.
So let me ask you this question. Understanding that, there's the loss side of things. Where would you, if you're talking with an employer who is being crushed by the cost of healthcare, and I think it's really sad. As a matter of fact, my son, my oldest boy is a nurse as well, and was talking with his family about, insurance because they still don't have insurance. And but for their family of five, healthy family, no comorbids or anything like that. I mean, they bike everywhere they go. Their monthly premium would be $1,600 a month. And that's for a high deductible plan. They'd have to blow through 6,000 before they could access anything. So I think we see where, a lot of employers, I mean, largely due to the market forces you just talked about, where we have to shift this cost onto these families who they choose to invest in other things for their families because, I can't use this benefit anyway. So, where would you tell an employer in terms of low hanging fruit? I can think of a few really high, when I think about low hanging fruit, I think of the high cost, those catastrophic claims, or it's only like maybe 3 to 5% of your population that's blowing up the plan that you talked about earlier. What would your counsel be for an employer who's looking at, how am I going to afford to, keep putting together, you know, benefits that are going to attract the kind of people I want? Where do I cut? Where do I find the low hanging fruit?
Well, the lowest hanging fruit with the least amount of noise. And so we talk about, and this is Deb's term. She calls it the teeter-totter. It's a seesaw. The seesaw on one end is per employee per year cost, which is the way we measure the cost per employee per year for a health plan. So divide the total spend by the number of employees on the plan, and not members, employees, and you get the PEPY. On the other end of that teeter-totter seesaw is noise, employee noise,
Mm-hmm.
disruption, unhappy employees. If you want less noise, you've got to spend more. If you want to spend less, you're going to have to tolerate more noise, because as you change things, people don't like that. And sometimes there are legitimate complaints. My doctor's not in the network. Other times, we had one HR director tell us that the TPA, their administrator, changed the insurance card from a white plastic card to a cream colored plastic card. And an employee actually came into her office and complained about it. So noise will happen. Noise is going to happen. The lowest hanging fruit with the least noise is pharmacy. So if you are self-funded and you've got a BUCA TPA, you've got to be big enough, which is usually like 10,000 lives, unfortunately, to go carve out pharmacy. The much easier way to do it at any size of employer is get an independent third-party administrator.
Mm.
Get one that doesn't require you to use their buddy PBMs where they're in on the graft. But if you get a good independent TPA Then you can carve out pharmacy and put in a fiduciary PBM. What do I mean by fiduciary? A PBM that says, I will not do anything to benefit me at your expense. And I will disclose everything we're doing. You can see where we're making our money. I am liable for your money like you are. I'm a capital F fiduciary. And then you can also carve out specialty and high cost maintenance drugs. And there are multiple ways to source those outside of the PBM. And we're talking about reducing the employer's cost 70 to 100%. And the employee pays nothing, no out of pocket, no $400 monthly copay on some of these expensive drugs. So I would start with pharmacy. And the reason for that is pharmacy well, first of all, everybody gets their drugs, so nobody's upset. So there is no noise. Second, there are two groups in pharmacy. One is a few people taking very expensive drugs. So to your point, Kimberly, they are outliers, but they're very expensive outliers. Yeah. And then you've got a whole lot of people taking inexpensive drugs, relatively inexpensive drugs. They're still way overpriced, overpriced. And so the volume of generic drugs can be cost saved. And then the expensive drugs, not as many of them, but you're going to save a lot more money on each of those. So there's those two separate groups. Then outside of drugs, which is actually very easy to do if you have the right administrator and the right advisor. So this goes to who is helping you run your plan, what type of healthcare consultant or advisor do you have? If you don't have a good one, look for one that is labeled next gen or next gen benefits because they practice these principles. And then you want to make sure you've got an independent third-party administrator that will allow you to bring in the right pharmacy for you, the right PBM and cost containment on the expensive drugs. Now, that's pharmacy. But let's look at drugs that don't go through the pharmacy. They go through the health plan. And most of those are the infusion drugs. Mm. Can I get an amen, ladies?
Amen. Everyone turns to J code.
Yeah, J code.
So we're talking about J code drugs.
Absolutely.
And these drugs, I used to have an employee who, before she came to work for Next Gen, she was a practice manager for physician practices. And we're talking about like multi-million-dollar, $100 million physician practices a year in revenue. And the last one she worked at was an oncology practice. Oh, yeah. She ordered the oncology drugs, the infusion drugs. She knew what she paid. She knew what they charged. And the markup is unbelievable.
Yeah.
So there are no cost controls when you are buying your oncology drugs through the medical plan. There's no PBM. Even if you've got a great PBM, there's nobody looking over the doctor's shoulder on these drugs. So when you can get those drugs administered outside of the physician practice, you know, it's my friend, Dr. Kristen Dickerson, founder and CEO of Green Imaging, which is a cost containment program for diagnostic imaging tests. She loves to ask the question, do you know where the most expensive diagnostic test is? You go, how would I know that? She goes, oh, it's easy. Down the hall.
Yeah, that's right. I've heard her say that. Yeah.
So when the doctor says, I need you to take an x-ray or I need you to get an MRI, he take this order, hands you a piece of paper, and go down the hall.
That's so convenient.
To their imaging center. It's the most expensive place you can do it. There are freestanding imaging centers. Well, in the same way, if you can get the infusion drugs or the the infusion out of the doctor's office and into an independent infusion center. At the very least, if you can source the oncology drugs outside of the doctor or the hospital, that's where you're going to save a tremendous amount of money. And the same with dialysis, which is a huge cost, and it's an ongoing cost. At least infusion drugs aren't taken for years. Dialysis.
Although a lot of these oncolytics are becoming more maintenance, maybe not infusions as much as the orals, but they're still plenty spindly.
That's okay. Keytruda, a good example
absolutely.
of that. As long as you're alive, you're going to be taking Keytruda.
Yep.
And so, but that's a great point. But dialysis goes on for the rest of the patient's life
until they get a transplant or die.
Yeah, for years until they can't go on any longer. So if you can get that out, if you can carve that out and send that to a separate vendor that is looking after the cost. So you want high quality, but that quality doesn't have to cost as much as it does. The markups are truly
absolutely. Well, here's a question for you.
So many ways.
Absolutely. I mean, we've had folks who are dialyzing outside of the U.S. The average, billed charge is about $300 per treatment, where here in the States, it's like $9,000 or $10,000 a treatment. But, it's interesting. So here's a question for you. Because we're talking about some of the easy, low hanging fruit. When I think about pharmacy, and I think about dialysis and MSK and cardiac. And dialysis has a lot of legislative support around it, right? We've got the Supreme Court backing that's allowing the employers, standing behind the employers, to be able to carve these things out. Where's the legislative support in the pharmacy space? Is there any?
I have a friend, an acquaintance, who went to see Congressman Paul Ryan when Congressman Ryan was Speaker of the House of Representatives in Washington. He was a Wisconsin CEO, went to see Paul Ryan at his district office back in Wisconsin. And this CEO is very savvy on healthcare. And he said, Paul, you know that the ACA, Affordable Care Act, for better or worse, was not insurance reform. It was not healthcare reform. It was insurance reform. Paul Ryan said, yes, I know that. My friend said, Paul, Congress has to address the cost of healthcare.
Yep.
And Congressman Ryan looked at my friend John and said, John, Congress will never, ever, ever address the cost of healthcare. Now, my friend John Turinas is a CEO. He's used to getting things done. He looks at Paul Ryan and says, why the hell not? Paul Ryan looks at him and said, John, there are 4 healthcare lobbyists in Washington for every member of Congress, and untold hundreds of millions, even billions of dollars available to donate to you or your opponent, or fund a primary opponent. The expression is, will primary you. Run someone in the primary against you who's more favorable to their position. Congress will never, ever, ever address the price of health care.
Well, and when
drugs, you asked about drugs. No. There's just
billions.
Too much damn money.
Yeah.
And
the tentacles tentacles run so deep, to your point, to the very upper chambers. So yeah, it's interesting. And where you look through history, where there has been attempt at legislative support for that, you just find a way to get back to the money, right? Like the MLR.
So ladies, the answer is money. Now, what's the question? And that's what's going
Consumer.
on. There is just so much money.
Yeah.
And the people who have it want to keep it. The only changes that we're seeing, the only changes that are going to have any impact are not legislative.
Right.
The transparency rules. Brokers are, employers are required by law to request a full compensation disclosure from their brokers. Do you know how often that's happening? Why? It's not. Why? Because nobody's enforcing it.
There's no teeth.
There's no penalty for not doing it.
Right.
And if you look at the transparency around hospital pricing, hospitals have actually posted on their website, we are required by federal law to provide actual pricing data for all of our procedures. We feel that doing so would confuse the patient and lead to more problems. So we're going to accept the fines and refuse to do that. They're just flat out saying, no, fine us.
Yep.
Fine us, because it's not enough.
Yeah. Or they'll tell you they post it. I recently went through this at a facility for my mom. They tell you that they're posted. You can't find it anywhere. When you reach out and you call them, nobody calls you back. You can't get anything.
Well, even when you put it up, it's a machine readable file.
Yep.
Now, I don't know about you. I've been called many things, but I've never been called a machine. Right?
You need a Leon.
The average person can't read it. It's machine readable, whatever that means. And the laws that have been passed to address PBM abuse and drug pricing abuse, none of those have any teeth if they ever get passed. Here's what does have an impact: the courts, lawsuits.
If those fines are meaningful, to Rusty's point earlier, right? If it's not just a cost of doing business.
Well, no, to some extent, it is just flat out a cost of doing business. This is not a drug issue, but one of the major insurance companies, insurance brokers, Gallagher, I will name this because it was a federal lawsuit, it's public record. Gallagher was sued in federal court by Osceola County School District in Florida.
Oh, yeah.
Large school district, 10,000 employees. They had hired Gallagher to advise them on which insurance company should they hire to manage their self-funded plan. Gallagher agreed to their contract terms, which was, we will accept your fee. I think it was around $70,000, something like that, for our services. And we will accept, according to the contract, no additional funds from any party. That was the agreement. Years later, 4, 5, 6 years later, Gallagher was dragged into federal court by Osceola County, that school district, for taking, they had recommended Cigna in year one. They were still recommending Cigna 3, 4, 5 years later. Gallagher, according to Osceola County's charges, took $4 million under the table from Cigna, unbeknownst to Osceola County School District. Gallagher took their high-powered attorneys, went into the federal court, told the judge, this is ridiculous. There's no basis to this. You should dismiss this. We seek summary judgment. Dismiss it. The federal judge issued a ruling, which I have read, where she said, no, there's plenty here to go to trial. We are going to trial. And Osceola County School District is seeking damages, not just reimbursement, but damages. And damages require some additional behavior like fraud. And we feel there is plenty of evidence that that may have occurred. That was the federal judge's ruling. I read that and said, well, they're not going to ever go to court. Gallagher will settle. And they did. Gallagher is accused of taking $4 million under the table. They settled with Osceola County School District for $500,000. Now, I don't know about you, and then the lawyers cost something, but what are the lawyers? Let's say $500,000. 500,000 plus the 500,000 that they paid Osceola County School District, it's $1 million. They took 4 million under the table. They netted out 3. That's a pretty good deal.
Yeah.
Do you think that will stop them from doing it again? No, it won't. You have to keep going back and keep going back and keep going back to court. But that's the problem. It's a cost of doing business.
Yeah.
And so the Richard Branson told me when he asked to explain U.S. healthcare. So I explained misaligned incentives. That's pretty much it. He looked at me afterwards and said, based on my experience, I know for a fact companies will not change, he said. They will not change their behavior until their incentives change.
Right.
Well, that's tautological. Yes, of course. But it raises the question, how are you going to change their incentives? You make what they are doing today not as profitable because you're doing it another way.
So bring in the consumer.
We're not going to hire you as a fully insured insurance company. We're going to go self-funded. And then enough companies do that where it's only the unhealthy companies that are still fully insured. Well, that's not a sustainable financial situation for the insurance company. They'll have to change how they do business.
Yep, absolutely. That's my polite clap.
It's really helpful for folks to join ecosystems, Ascend Next Gen being one that is very predominant. But there's, numerous organizations out there like SIA, the Self-Insured Institute of America, and so forth. And all of these organizations help to educate. They help to create awareness in a non-proprietary format, so it's not only accessible, but it is supportive to sharing amongst leaders and really helping to bring together business owners, I think is going to be critical because what we're seeing is pharma goes to the hill together, hospital lobbying goes to the hill together. If employers, broker agencies, and folks on the right side of this healthcare ecosystem, if they're not moving that mountain together, then it will feel exhaustive and it may not have fruitful results. But it's just really important to join into that movement through ecosystems and support groups that are willing to have transparent conversations, educate, and move those mountains together. And this is where we've seen, for example, states trying to lobby that would severely hurt the self-funded market in that area. For example, trying to ban white bag products into hospitals or facilities. I don't know a single hospital who's manufacturing pharmaceutical products on site. It's all brought in. If it's track and trace paperwork through a quality, URAC, ACHC specialty pharmacy, it's the same distribution as the manufacturer uses for patient assistance programs, for example. But we saw, a big effort in states where hospitals were pushing to ban white bagging, and it wasn't until employee-sponsored plans fought back and really said, no, this would severely hurt the performance of our plan and our ability to provide high-quality, insurance plan offerings to our membership, et cetera. That in states where that wasn't activated, that response to combat it, you'll see that it was passed. And in other states where the employer groups band together through ecosystems and education, they've been able to ward it off. So I just highly encourage folks to get in touch with resources like Next Gen Benefits and really become an informed party of this ecosystem. And that will be a key contributor to moving things forward or keeping things at least where they're at today and not worsening the market.
Rusty, we talk about the Next Gen Benefits movement, that this is we're not just an organization. It is a movement of diverse individuals, organizations that are banding together very loosely. We don't have membership cards. We're not a membership organization, but the idea of making common cause and well, if nothing else, encouraging one another, because this gets very challenging in the marketplace. And so my background is actually public policy. I ran think tanks. I was a lobbyist, and I know that world pretty well. The role that we have to play, the only role that we can play in the political, not the political, the public policy world, the lobbying, the legislative, is to stop what's known as rent seeking by interested parties. Rent seeking is simply looking for a financial advantage from the legislature. So eliminating white bagging protects the hospitals and the doctor's offices from having their margins cut or eliminated on J-code drugs. You're not going to get anything good passed. Their lobby is too strong. But we can, as you pointed out, have an effect and an impact and get positive results by fighting the rent seeking, fighting the bad legislation that sustains and reinforces the status quo. And what I'm saying here is I don't want us to get off on these, because I can tell you it won't be productive. Oh, let's get a bill passed to make it illegal for the drug companies to do spread pricing, the PBMs to do. That's not going to pass. So we're wasting. Now, the only reason to do it is maybe to educate, but educate who? You educate legislators doesn't make any difference because it's not going to pass. If you could educate the public around that at the same time, but that's a public relations and marketing initiative. You don't have to go to Capitol Hill to do that. So I want us to be realistic about our expectations, so that we can marshal our forces and challenge funnel our energy in ways that are productive. So fighting bad law or bad ideas, the legislature. Yes, that's great.
Plug for Ethos, Chelsea and Donovan, what they're putting out with their feature films to really educate employers and get the consumer arm going. I think it's so, I would love to see that. I would love to be able to see that on my Roku or Netflix, where people can have their eyes opened and then start to demand, because really our industry, healthcare, is the only industry where the consumer has no voice. It's kept murky by design, right? Because we don't want them to have a voice. Just keep your eyes closed and move along. But some of these movements that we're seeing, I think there's a beautiful power there. So,
did you ladies see The Matrix, the movie The Matrix?
Oh, absolutely. Keanu Reeves.
Not
a fan, big fan.
Patients in the U.S. healthcare system are not too different from all of those bodies plugged in, providing energy into the matrix and being fed images that aren't real.
Yep.
It's very analogous to that, because we are basically, as patients in our healthcare system today, we're basically a transaction.
Mm-hmm.
Without us, there is no money that gets passed. Without a patient, there's no money. But with patients, there's lots of money. So you are a transactional vehicle for healthcare, and they'll tell you all. So watch the Blue Cross and United and Cigna and Aetna commercials. And you go, oh gosh, they're so wonderful. Oh, throwing the little baby up in the air and catching the grandfather. It's like, oh, I want to live a United healthcare life. So we're fed these false images, but we're
Propaganda.
plugged into the system to feed it.
Yeah.
And
I
actually,
think fee for service.
when you get an IV, or you're having blood taken, you literally are feeding the system.
I think it's interesting that we're still paid at large as an ecosystem for fee for service, which when you think about that in any other structure, right? If I need a HVAC to come in and fix something in my home, I understand I have a fee for the service that they're there. But when you put fee for service in the concept of healthcare, that's fee for sick, right? And it's really thinking differently, to the point that Nelson made earlier in today's conversation, that there are disaligned incentives. Until we change over the incentive, we are not going to be able to, move all these mountains alone. And I think it's really interesting that we've talked about value-based contracting in healthcare as this like proverbial goal that no one has really taken, in my humble opinion, severe steps to actually pursue in the fully insured market, or in a way that is, not directed by a excelled broker with a high performing health plan with a self-funded employer group using somebody like AIM, for example. It's otherwise unheard of. And I think that it's a really interesting concept that everyone just keeps feeding into this fee for service or fee for sick, instead of thinking about how do we pay based on performance.
Yes.
That's control of the provider or the healthcare ecosystem, and really thinking about shifting that dynamic so that way there's skin in the game, not for egregious pricing or price gouging, but actually for the clinical results and the wellness of a patient. And I love the DPC, direct primary care movement, and there are things that are moving toward this, but I have not seen those activities outside of high performing health plans in an organization or movement like Next Gen Benefits. It's otherwise just really unknown, unheard of, and unquantifiable within most structures.
In Next Gen, we talk about healthcare revolution, and that what we're doing is revolutionary. But in fact, dirty little secret, there's nothing revolutionary about what we're doing in healthcare. It is revolutionary in healthcare, but these are practices that every company uses in every business unit in that company except healthcare. So let's see, managing the quality of what we buy. Oh, no, we don't care about the quality of those ball bearings. Just find the best price. No, they have to be spherical. If ball bearings aren't perfectly round, they don't work. Are there people out there selling ball bearings that are not perfectly? Yes, they are. And you can get them for a good price, but that doesn't serve your purpose. So we look at quality and then we negotiate price. What a novel concept in healthcare. I had a conversation with a supply chain expert. He was managing the supply chain academy at the Indiana University Business School, and was teaching supply chain to the graduate students, the MBA students. But previously, he had spent 30 years in supply chain as a senior executive in large companies in Detroit. I called him because I was looking for someone to manage and build a healthcare supply chain certification program. Get him on the phone. I tell him what I'm looking for. I'm looking for someone to build a healthcare supply chain management certification program. I'm not your guy, he said. Like that quickly. I said, well, okay, maybe not, but can you tell me why you said that so fast? I don't do hospitals. I'm in manufacturing. Oh, I'm not talking about gauze, syringes, and bedpans. I'm talking about physician visits and surgeries and diagnostic testing and drugs. He said, what are you talking about? I said, I'm not talking about what hospitals buy. I'm talking about what employees purchase in the way of health care. For instance, one of the employees at one of your former employers will get diagnosed with a heart problem that's going to require open heart surgery. He will go to a surgeon whose quality outcomes no one checks. He will have his surgery done at a hospital where no one has looked to see if they have an infection problem or what their outcomes are for this particular surgery. And 6 weeks or so later, the company will get an invoice for a price that no one has seen, heard, or negotiated. He said and I will use the initials for what he said, BS. We negotiate the price of ball bearings, he said, down to 1/10 of 1 cent. And you're telling me no one's negotiating the price of a 6-figure heart surgery? I said, that's exactly what I'm saying. He said, can you prove that? I said, all day long. Keep talking. You know what he's doing today? He did build our certification program. Today, he's calling on his old employers, asking them, what are you doing to manage your healthcare supply chain? And he's serving that function as a consultant. The point is, there's nothing new here. It's just new in healthcare. But getting employers to break free of the current system where they delegate anything related to healthcare to an insurance company and a broker, and then assign a line manager in HR oversight of their second or third largest operating expense is insane. But that's common practice. One CEO recently told us that healthcare is just a cost of doing business. Is what it is, cost of doing business. I think, no, it's cost of getting screwed.
I was recently speaking with a broker who was trying to explain all this to a self-funded client who's recently transitioned out of the fully insured market. And they were talking through a significant high dollar case where the claimant was going to need continual therapy for the rest of their duration, either on plan or life. And it was an interesting thought where they were discussing, I don't want to make changes to the healthcare decisions. I don't want to tell my member where to go. And, I know that this is high dollars that we're talking about. It was over 6 figures annually, year over year. But, I'm really not comfortable with thinking about this through the current structure. And the broker looked at him and said, if this employee came to you and asked for a raise of 6 figures year over year, what would you do? How would you equate value to that? And they started changing the dialogue to, instead of thinking about making a healthcare decision, make an employee contribution decision. And I just thought that was such an interesting way to think about it, because what is spent on healthcare is part of a benefit package with compensation and other factors. And it was at that moment that the employer, I saw the aha light go off in their eyes when this discussion was happening, where I was like, that was such an interesting concept to start discussing it as part of a compensation package, not to, challenge the employee who needs that type of support or help or healthcare service, but to think about it in essence of, how do you control it from an employer perspective, looking at it like you would any other part of their compensation package. And I just thought that was a really interesting view into a different dialogue.
I love that question. And that is going to make its way into some of my presentations. Thank you for that, Rusty. Another approach that I take and teach my advisors to use is to ask, because for some reason employers do consider healthcare different than anything else in their company. It's like, well, I don't want to tell my employees which doctor they can use or which hospital they can go to. Okay, well, that's fair, I guess. Do you do anything, Mr. CEO, CFO, to control they call it the mod rate, which is simply the renewal costs, new renewal increases on your workers' comp insurance? Oh, yes. Yeah, we take that very seriously. Oh, well, what do you do? Well, we make our employees wear who work in the certain areas, they have to wear that big black elastic belt around their waist to help secure their back and eliminate back injuries. I said, okay, yeah, that's great. What else? Well, we do drug testing. I said, oh, how do you do drug testing? Well, they have to urinate in a cup. We do a urine sample. Oh, so you make them pee in a cup? That's not intrusive at all. That's and so why are you willing to mandate those sorts of behaviors to reduce an insurance cost that's far less than your healthcare cost. All right, I'm going to get on my hobby horse here for just a moment. I believe that employers need to start, we make it voluntary now. I think employers need to mandate certain behaviors around their health care, because it's not just that employee's choice and that employee's expense.
Right.
That expense affects every other employee.
That's right.
They're all subsidizing that
Correct.
bad decision to go to that very expensive doctor in that very expensive hospital, both
Yep.
of which have low quality scores, low outcome scores, poor outcome scores. So
Yep.
that when they have to go in for a second surgery to fix the problem the bad surgeon created in the first surgery, the health plan pays for that. They pay for the readmission to
Yep.
the hospital, which means the employees pay for that.
Right.
Some of you, both of you probably are familiar with Walmart's Centers of Excellence program. It's
Absolutely.
been around for years. Walmart and the late Tom Emmerich, who I had a chance to get to know before he passed away, Tom Emmerich came up with this idea. He said, we are going to send our associates to the best possible facility for the best possible care for whatever it is they need help with. So if they need heart, you had to go to Cleveland Clinic back in the day. They have regional centers of excellence now, but back in the day, it was just Cleveland Clinic. If you had, I think, neurological issues, I think you went to Johns Hopkins, I think, or Mayo Clinic, someplace. But you had to go. And here's the thing. They would pay for you to fly there with a caregiver, spouse or friend. They'd
Yep.
pay for your hotel. They'd pay for everything. You don't want to go to Cleveland Clinic. You want to stay here in Bentonville and go to Bentonville Regional. Well, that's fine. You can do that. But you'll be paying for the entire thing out of pocket.
Right.
We're not paying for a penny. We will only pay for the best care.
Well,
I
and look at it.
don't.
Look
Go
at how
ahead.
compassionate that is. Most people, when they have to have a serious procedure done, being a nurse, I've had lots of people say, well, who should I go to? Is Dr. So-and-so good? Or what do you think of Dr. So-and-so, to your point earlier, right? Most people actually want that information, right? They don't want to be told, what to do. But I think when employees understand, because they don't, right? That model where you're going to save money doesn't equate, because they're used to, your point earlier, more is better. So as we educate employees that this is where the best care is, and the best care costs less, it's the exact opposite of any other industry. And I think most people, if they understood that, that was the rationale behind it, I think most people would appreciate that, because they don't have any reliable way to ascertain, where do I go to get the best care? But everybody's hungry for that information.
Well, let me put a
Thank you.
cherry on top of this sundae. I was with Tom Emmerich at an event. We were both speaking there, and we had a few moments of downtime. And I said, "Hey, Tom, how did you negotiate pricing in your Centers of Excellence program when you set that up? Did you use Medicare as a reference price, like reference-based pricing?" He looked at me with a funny look. He said, "We never negotiated price." I said, "Well, I understand that the Centers of Excellence program has saved Walmart hundreds and hundreds of millions of dollars over the years since you implemented it." He goes, "That's right." Then if you didn't negotiate price, how did it save all that money? He said, "Oh, that's easy." So the patient in Bentonville, who was told by his doctor in Bentonville, Arkansas, that he needed open heart surgery, goes to Cleveland Clinic, and Cleveland Clinic doesn't just do the surgery, they do an exam. They're going to do a second opinion.
Mm-hmm.
And they will look at him after their tests and their analysis, and they're going to say, "Yes, we're really pleased you came to Cleveland Clinic. Now go home. You don't need open heart surgery." It's the avoided care, not the denied
Wow.
care, the care that should not happen in the first place,
Yeah.
that has saved us all that money. That, and not having second surgeries because the doctor screwed up in the first one, not having readmissions because the patient got MRSA because it was an unsafe infection-ridden hospital. That's where they saved money. They didn't, the price was not even a consideration. High quality was a consideration. And it has proven over decades to pay dividends. Oh, by the way, patients are back to work faster.
Yep.
They don't have any complications. To show me a patient that wants to go in for a serious procedure, surgery or otherwise, and gets to go back and do it again. Show me one that goes, yeah, I want to do it again.
Yeah.
Right. Well, they want it done once and done right. What the old saying in carpentry,
Yep.
measure twice, cut once.
Or
It
don't
applies in
cut at all
healthcare.
if you don't have to cut.
Or in healthcare, yes. Do you even need to cut?
Yeah.
And that's where so much of healthcare, misdiagnosis is a huge issue. I have a whole presentation. In fact, I'm giving it in where in Czechoslovakia, in Prague, next year on misdiagnosis and the value of second opinions. It's not just U.S. healthcare; it's healthcare around the world that has this problem. But misdiagnosis is a huge
Yeah,
issue,
absolutely.
and you don't catch it unless you do a second opinion.
Yep.
And without that second opinion, the first opinion rules. And so somebody ends up getting cut or taking a certain drug or getting some procedure that's not necessary, which is often detrimental. It's not just not needed. Who wants to get cut
Absolutely.
open for any reason? It's trauma on the body.
Yep. You can never uncut. Absolutely. You know, Nelson, I think I could talk to you all night. So Rusty, Nelson, next time we all are together, pizza and root beer on me for sure.
I love root beer. My favorite soft drink.
It's not good for you, but it sounds good. Well, let me ask you this: as we wrap up, if you could, what would your call to action be, so to say? If you would have a broker, advisor, an employer who might be listening, what would be one key takeaway that you would most hope that they put in their pocket to bring out at their earliest opportunity to make a difference for their plans?
My personal suggestion would be to get a second opinion on your plan design from independent consultants that are not currently in your broker of record or agent of record placement. And that just helps to bring creativity and or great discussions back if you want to continue with that current relationship. But it also holds folks to an accountable level of staying up to date in market and continuing to perpetuate education. And so the same way that we're asking for second opinions from physicians for patient care, I think we need to think symptomatically at plan design that same way. And so I encourage or to seek out folks who are already acknowledged as excelling in that area. Again, throwing out next gen benefits, mastermind consultants. Those are folks who have studied and essentially been credentialed in this space. And they're going to have a lot of information and ability to educate that you may not be getting currently in the market.
That's a good one. I love that.
I actually made a note of that, Rusty. That's applying second opinion to your health plan. That's a terrific idea. I think too, and this was a big, big pivot point for next gen benefits, is what is the conversation that you need to have with the employer, and with whom do you need to have it? HR are wonderful people, but they are operational. They are implementation. They do not own a profit and loss statement. They are not strategic. They are not financial. Healthcare is well, and next gen benefits, healthcare in terms of next gen benefits is a strategic financial conversation about the healthcare spend, its impact on business objectives, and managing that cost to help that spend achieve business objectives. That's not a conversation you can have with HR. This is a C-suite conversation. CEO or CFO. If it's a large organization, they might have a CHRO, Chief Human Resource Officer. But it's got to be with one of those three, or you're talking to the person who hired the incumbent broker,
Yeah.
who doesn't know any better and doesn't have any incentive to change the way things are being done. But if you're talking to a corporate decision maker with fiduciary responsibility for the health plan as well as the company, who has P&L responsibility, financial responsibility, and who isn't married to the current solution, that's who they need to have the conversation with. Then go in and talk about a second opinion on their health plan. The question, here's a question. This is the question I would give employers or advisors to ask employers, or employers to ask themselves. What are the business objectives for spending all of the money you are spending, Mr. CEO or CFO, on your health care for your employees? What are the business objectives for spending that much money? They don't know. They've never thought about it. We have to. No, you don't have to. There is a fine if you're over 50 employees and you don't offer health care. It's a lot less than you're spending on health care. Pay the fine, take the rest, put it in your bottom line. No, why not?
Yeah.
And the reasons are pretty much universal. Retention of employees, recruitment of employees, productivity, and I want to take care of my employees. Those are the only four reasons that you spend that money.
Yeah.
Then ask yourself, Mr. Executive, how well your current health plan is helping you achieve those four objectives. High retention, very, very competitive in hiring the best talent, extremely productive employees, and you're really taking care of your employees with a low out-of-pocket, low deductible, low co-insurance, and an affordable premium. If you're getting all of that, congratulations. If you're not, talk to an advisor who can help you get those objectives met with your current healthcare, not with your current, by replacing your current healthcare plan.
So for Nelson and for you, Rusty, Nelson, how do people find you? Like if somebody says, hey, I want to learn more about where I can find a good next gen type of benefit advisor, how do people find you? How can they get in touch with you and your team?
Extremely easy. Next Gen Benefits, NEXTGEN, Next Gen Benefits.network is our home on the internet. nextgen.net, nextgenbenefits.network. And you can reach me at Nelson at nextgenbenefits.com.
And you're all over LinkedIn, one of my favorite folks to follow too. Thank you so much.
You can find me on LinkedIn occasionally.
And Rusty, for folks who want to know more about, how you can help them with that lowest hanging fruit there, how do people get in touch with you?
Yeah, so I would say our website is a great initial start at Optimed, OPTIMEDHP.com, or reach out to myself. My first name, Rusty, RUSTI.Grice, GREIS, at OptimedHP.com as well is my email. And we would be honored to support just open dialogue. We're a big proponent of educating, and when you already have a great plan design or a great solution, we will be one of the first to say you are achieving, a higher than market average or exceptional contract pricing. There's nothing further we can do. The same thought when you're reaching out to a broker. If you have a really strong broker, no one's going to be able to add new dialogue to that conversation, but at least you've second opinion, you've market checked yourself in the plan performance, and you now have the opportunity to take that education either to continue your current relationship and structure or to make changes that would be positively benefiting you and your membership.
Amen. Nelson, we can't thank you enough for taking time out to talk to us. It really is always a treat. I always come away smarter. I still remember the first Next Gen Benefit gathering I got to go to. I asked you for a long time, am I going to be smarter when I come away? You get it. It was guaranteed. Every time I speak with you, I really appreciate not just selfishly what I learned, but really appreciate the work that you're doing to make an industry I really care about so much better. I mean, at the end of the day, if we're not working to make this industry better, someday we're going to be sleeping in the bed that we made. And I hope that there's something good there for us when it's our turn.
Well, coming from you and Rusty, both of whom are doing such great work on the clinical side, y'all are making it happen in the trenches. So I'm working with the advisors who are helping the employers do the right thing, but you all are the right thing in your niche.
Aww.
So it's, and I'm going to go back to something you said earlier about bringing clinicians into the conversation. We have found that and usually it's like a direct primary care doctor is usually who we end up going into a meeting with. But when you take a clinician into a meeting with a CEO or CFO, not HR, but a CEO or CFO, the conversation changes.
It does.
The attitude, because that doctor or nurse, I could take either of you in from a clinical standpoint, Deb Alt, if I could take Deb in, the conversation is going to be the same. It's about why we spend the money in the first place. It's the care. It's the health care system. And you're not paying for health, you're paying for care.
Yeah.
And the clinician can speak to the delivery of that care, the quality of that care, the cost of that care in ways that the advisor or broker cannot.
Right.
So I strongly urge advisors to find a clinician, somebody who can, or someone who works with a clinician, a clinical organization. And Rusty, just listening to you talk, I mean, you really, really understand what's going on, and it's because you're immersed in that world, and you're really smart.
Oh,
Kimberly, you're really smart. You're a nurse, and you're immersed in that world. So you both bring an incredible amount of knowledge and expertise. So I would take either one of you in to see an executive, because you can speak to the problem. So being on with you guys is a thrill. Thank you for having me.
Thank you so much, Nelson. I can't wait till we talk to you again.
Look forward to seeing you. January, Ascend in Nashville. I hope you both will be there. You should be getting information on it this week.
Hot dog. It's coming. Gosh, it's less than a quarter. We're a quarter away.
Fast. Yes, I know.